Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Boehringer Ingelheim and Eli Lilly Alliance.
Hello, I'm Shelley Zeroth, Professor of Medicine at the University of Manitoba and Head of the Medical Heart Failure Program in Winnipeg, Canada. Welcome to this program titled SGLT2 Inhibitors in the Post-MI Population, Answering the Last Unanswered Question. Joining me today are Mirvat Alisnag, Director of the Catheterization Lab at the King Fayed Armed Forces Hospital in Jeddah, Saudi Arabia. And we have Stefan Anker, Professor of Tissue Homeostasis and Cardiology and Metabolism at the Charité University in Berlin, Germany. And of course, Javed Butler, Distinguished Professor of Medicine at the University of Mississippi in Jackson, Mississippi. It's great having you all here today. Thank you for joining us.
Pleasure.
Today, we're going to be having an exciting discussion about the role of SGLT2 inhibitors in the post-MI population. Really, there's three clinical presentations differing in pathophysiology, clinical characteristics, and outcomes that can be identified in the post-MI population. You can have heart failure onset at the time of the MI presentation, heart failure developing during hospitalization for MI, as well as heart failure onset after discharge from hospital in the setting of established ischemic cardiomyopathy. We've really made a lot of progress in terms of impacting the size of the initial infarct, reducing expansion of infarct, and even overall global remodeling by our therapies and revascularization strategies. And I think what we're seeing is a reduction in event rates as a result of these advances in the setting of MI patients. Now, there is an ongoing risk of developing heart failure after an acute myocardial infarct. And in fact, in this cohort of 337,000 patients hospitalized with acute MI and no previous history of heart failure, nearly 1 in 5 patients developed heart failure after 5 years. And this is a fairly contemporary cohort. So there really is still room to improve outcomes for patients who are having a myocardial infarct and hopefully avoid an occurrence of heart failure. And in this particular cohort, those who are at an increased risk of developing heart failure after myocardial infarction were those with an older age, interestingly female sex as well, those patients with diabetes, reduced EGFR, and even atrial fibrillation contributed to an increased risk of post-MI heart failure. So now that we've reviewed the burden and occurrence of heart failure post-MI, Stefan, can I ask you to go over some of the historical studies which have really impacted our care in this patient group?
Yeah, thank you so much. There were several trials in the past and studies looking into different compounds being tested in a post-MI scenario. Of course, you all know ACE inhibitors, ARBs, beta blockers, MRAs are amongst these. And if you talk specifically about ACE inhibitors, if you remember the SAFE, ERROR, and TRACE studies, they all showed reductions in mortality and hospitalization and actually also reverse remodeling data. So we are using ACE inhibitors, of course, in the post-MI setting. And if maybe a patient doesn't tolerate it, if you prefer ARBs for other reasons, the Valiant trial has shown that there is equivalence of using an ARB to an ACE inhibitor. Now, the story with beta blockers is interesting. The Capricorn trial showed us even a reduction in all-cause mortality and got approval for this. We are now regularly using all these drugs. MRAs then with the Ephesus trial, I mean, there's a number of very successful MRA trials in heart failure, but then extending this also into the post-MI setting showed large benefits in terms of reduction in mortality and hospitalization.
Great. So let's move to some more contemporary studies. Mervat, can you tell us a little bit about the Paradise MI trial and the role of sacubitril valsartan?
These trials are really important because they address a subset or a population that we don't often see in heart failure trials. So the Paradise MI really looked at, it was prospective, it looked at ARNA versus ACE inhibitor ramipril, enrolled about 5,600 patients and followed them up for 23 months. They included patients who had an acute myocardial infarction, LV ejection fraction less than 40% with or without pulmonary congestion. And they had one of the following, so either an age more than 70, AFib, diabetes, or a reduced GFR rate. And they excluded patients with prior heart failure and clinical instability. The primary outcome was cardiovascular death, first heart failure hospitalization, or outpatient heart failure for both ARNA inhibitors and ramipril. The trial itself did not reduce the primary endpoint in a contemporary, well-managed acute myocardial infarction population compared with ramipril. The rates were numerically lower in the ARNI group compared with the ramipril, and the composite endpoint included heart failure, all events of heart failure, not just the first one. And it did show some benefit with sacubitril and valsartan combination. There was a similar reduction noted in patients who had recurrent coronary events, primarily due to a reduction in coronary revascularization. And I think we need to keep these points in mind. But when we look at the remainder of the results, when we want to look at safety of these agents in the acute setting, so the safety endpoints, the most important that catches my mind is really the hypotension that was slightly higher in the ARNIs compared with ramipril alone. But when we look at the overall results and we look at them by subgroup, so what the type of myocardial infarction, non-STEMI versus STEMI, the majority of the events actually happened in the non-STEMI compared with STEMI patients, which was really counterintuitive. Initially, my thought was that full-on STEMI would probably have higher events rates, but that wasn't the case. But irrespective, there were the same findings when it came down to the primary endpoint. So I think these are hypothesis generating, and we're going to need to look at some of the other trials as well that are looking at MI patients specifically.
Great, thank you for that summary. So let's move on to Stefan now, and why don't we tackle the DAPA-MI trial and go over the clinical trial findings?
Yeah, thank you so much. And of course, dapagliflozin, empagliflozin are really well tested in CKD, in diabetes, in heart failure. And of course, also this was then extended to the post-MI setting. And the DAPA-MI trial recruited patients 7 to 10 days after an acute MI, which was complicated by impaired cardiac function. And the estimated sample size, very similar to the EMPACT-MI trial, 6,500 patients, dapagliflozin 10 milligram once daily or placebo. And originally, of course, this was really an events-focused trial. It was then decided to make this trial somewhat shorter for feasibility reasons and to change the primary endpoint. So what you see depicted as the primary endpoint is really the final decided primary endpoint, which is a hierarchical win ratio tested endpoint of a composite of death, heart failure hospitalization, non-fatal MI and atrial fibrillation development, new onset diabetes, the New York Heart Class at the last visit, and also whether or not patients had a decrease in body weight of 5% at least. And there was a key secondary endpoint where all these things were analyzed again, except that excluding the body weight component of this. When you then look into the results that were reported last year, the primary outcome with all these 7 components showed a win ratio of 1.34 that was significantly in favor of dapagliflozin with all these 7 components. And when you take out the body weight aspect, and clearly you can see by the reduction of win ratio that body weight did in a meaningful way contribute here. The win ratio was less, 1.20, but still very significant with a p-value of 0.015. Now, looking a little bit more detail into these results, there's some very interesting additional findings that were also really driving the primary result. Number one, less diabetes over time in the patients, 4,500 in the end recruited, less diabetes over time developed. And this is, of course, a good metabolic, cardiometabolic finding. And the body weight change was 1.6 kilogram. Now, beyond all of this, what about specifically death? What about hospitalizations? They are analyzed also, of course, as serious adverse events. And we had 30 deaths in the patients treated with dapagliflozin and 29 in placebo. So there was no difference. And hospitalizations occurred also in a similar number of patients, 18.7 and 17.2% of patients experienced this. Overall, there were no increase in serious adverse events related to the drug given itself. So hypotension and amputations, hypovolemia were not an issue.
Okay, so that covers DAPA-MI. Let's move forward to present day. So Javed, can you present the findings of IMPACT-MI? And maybe we'll talk a little bit about how clinicians will interpret that data.
Yeah, certainly delighted to. So IMPACT-MI, the inclusion-exclusion criteria were really all routine care and very broad, sort of get the broadest number of patients in the study. Focused data collection really was remote follow-up for the most part, except for one in-person visit. But importantly enough, we did not have central adjudication of the data. So we basically got the data from the site-based adjudication. So our primary endpoint was all-cause mortality and heart failure hospitalization. Now, patients who already have a history of heart failure at the time of myocardial infarction, they were excluded from the trial because they already have an indication for SGLT2 inhibitors. So these were all patients with ST elevation MI, non-ST elevation MI within the first 14 days of their diagnosis, but they required one of the two things. They either had to have congestion, their EF could be totally normal, but they either need to have congestion or a new drop in ejection fraction to less than 45%. We excluded obviously patients with type 1 diabetes and those with GFR less than 20. So that was sort of the patient population. So large trial, global trial, about 451 sites over 22 countries, 6,522 patients randomized. And despite of the fact that, you know, we sort of conducted this trial in COVID era in the beginning and then the regional wars and whatnot, we had vital status available in 99.2% of the patients. And the follow-up was about 17.9 months. So if you look at some of the patient characteristics, one is that the number of patients that came in to the trial because of the congestion was about 57%, and about 78% are those that had a new drop in ejection fraction, and then obviously about mid-30s was the overlap. About 75% men, about 30% or so with diabetes, about 10-15% with prior myocardial infarction. Now, here's what's interesting to note. You know, in the earlier comment, Dr. Lasnik mentioned that patients with STEMI tend to have now actually lower events because we've gotten so good with revascularizations and whatnot. Now, it's pretty interesting that in the real world, there are actually far more non-STEMIs than STEMIs, but in clinical trials, we end up actually enrolling more STEMIs. So here again, we had 3/4 of the patients who were STEMIs and about 1/4 that were non-STEMI.
Can I ask you as well about the diversity of the patient population as well?
Yeah, so we have about a little north of 80% of the population was Caucasian, and about the rest, which was non-Caucasian, was largely Asian population and relatively very little other minorities. Excellent baseline treatment. So whatever results that we're seeing is on top of really very, very good medical therapy. So about 90% of the patients were revascularized for their myocardial infarction. Same thing, about 80+% of the patients were on RAS inhibitors and beta blockers. Most of the data that we have seen with MRA so far is in the 30% range. So we were getting close to 50%, about 47%. And then finally, statin therapy and antiplatelet therapy was north of 95%. So primary endpoint. So the primary endpoint of all-cause mortality and heart failure hospitalization was unfortunately not met. There was a 10% relative risk reduction, but that did not hit the p-value. P-value was 0.21. Interestingly enough, the composition of the primary endpoint, there were actually more mortality events than hospitalization event, which sort of starts making you wonder whether the heart failure was systematically sort of under captured. And we have at least 3 reasons for that to be the case. One is that we are seeing more and more heart failure being diagnosed and treated in the outpatient setting, which we did not include in our primary endpoint.
Right.
2, the first half of the trial was solid in the middle of COVID. And then 3 were these regional wars in 2 of the regions that were very active in the clinical trial as well. And so all of this sort of starts making you wonder. So we did some extra analysis, I'll tell you. Secondary analyses that all included all-cause mortality, pretty much none of them reached a statistical significance except for all-cause hospitalization and all-cause mortality. That had a nominal p-value of 0.04, about a 13% relative risk reduction. Now, that's where this study gets pretty interesting. We have consistently seen in many, many trials that the risk of heart failure events go down by about 25 to 30% in diabetes and CKD and heart failure patients. And here, if we split the primary endpoint into mortality and heart failure hospitalization, we really didn't see much in the way of mortality, but the heart failure signal is really pretty much what we have seen in the trials. A 23% relative risk reduction in heart failure hospitalization, curves start separating early, continue to separate, sort of the things that we've been accustomed to seeing. And then, if you look at the heart failure, total heart failure burden, first and recurrent heart failure hospitalization combined, that actually gets more accentuated to 33% relative risk reduction. So the natural question the clinicians may ask is that, look, heart failure is one of the biggest reasons for bad prognosis and mortality. So if heart failure signal is so strong, why was there no mortality signal? And I think these are sort of the nuances of the trial. The average time to development of heart failure was about 3 months, and the follow-up after heart failure development was shy of a year, was not even a full year follow-up. And the number of deaths that occurred were in a very few number of patients. So we really can't answer that question based on the way the trial was. Now, here's another twist. Although we did not include outpatient heart failure in the primary endpoint, there was a protocol-specified heart failure adverse event that included heart failure hospitalization, death due to heart failure, or outpatient heart failure. So we did actually have site-based data on heart failure. So now if you look at the cumulative effect, both inpatient and outpatient heart failure in an exploratory fashion, what we find is that now it is even further accentuated the third time to 37% relative risk reduction. And for whatever it's worth, when we construct a exploratory endpoint of all-cause mortality and total heart failure events, that actually does meet statistical significance with 21% relative risk reduction. So we really wanted to pressure test this, right? So this is exploratory analysis, that outpatient heart failure. So what's one way to pressure test it? Well, one way to pressure test is that the patients who at the time of discharge were not on heart failure medications, but were started on heart failure medications after discharge. So if you look at ARNIs, RAS inhibitor, MRAs, diuretic use, all of those were a statistically significant higher chance, of about 25-30% higher chance of getting started in the control arm as compared to the empagliflozin arm.
So you think that the patients who are randomized to empagliflozin then were doing better, and
they were not developing heart failure in the outpatient setting. They were not being started on the heart failure medication, and this sort of indirectly corroborates the data of the outpatient heart failure that I was mentioning. Safety, really, I don't have much to say. The biggest question over the safety was, we have tons and tons of data on SGLT2 inhibitor safety in all patient population, including inpatients. So that really wasn't a big question for us. The big question was that, gosh, these are the patients that are coming into the hospital with MI. They're going to get IV contrast. They're going to get cardiac procedures done. They may get surgery done. And simultaneously, within a matter of 2-3 days, we're going to start new onset of RAS, new onset of MRA, and new onset of SGLT2 inhibitor, right? So that was a discomfort. So interestingly enough, there was absolutely no renal safety signal of concern at all, no increased risk of AKI, and the kidney AEs were similar. If you look at the overall AEs and AEs leading to discontinuation of the drug, it was no difference between the placebo and the treatment. So if you put all of these two data together, it was safe. Primary endpoint was not met, but there was a 23% first hospitalization, 33% total heart failure hospitalization risk reduction. So we said, you know what, how does this data fit into the big data with SGLT2 inhibitor? So we did a meta-analysis that includes all big SGLT2 inhibitor trials. And it turns out that there's about a 29% risk reduction for first heart failure hospitalization and 30% for recurrent, and impact MI falls right there. So if you now look at the totality of evidence, more so in a sort of a Bayesian way, the totality of evidence, at least to me, reads that empagliflozin reduced the risk of heart failure hospitalization in patients post-myocardial infarction, which is very consistent with the signal that we have seen in adjacent patient populations as well.
Great synopsis. And I think that reduction in heart failure hospitalizations has really caught the eye, at least of the heart failure cardiologists for sure. I'll get everybody's opinion on that shortly. So Javed, let's talk about the difference between the MPulse trial, which enrolled patients across a continuum of ejection fraction in patients, versus Impact MI. Can you compare and contrast that? Those two studies for us?
Yeah, so, MPulse, as you mentioned, was across the spectrum of EF, but they were heart failure patients. Now, they may include patients with ischemic cardiomyopathy. So they had patients post-MI, but remote history of post-MI, right? So in those patients, we already know that starting the therapy was safe and was efficacious relatively in the short term. And what Impact MI does is bring the history of MI from remote to current. So that's the patient population we studied, because now we have data with diabetes, with chronic kidney disease, with heart failure, and this is stage B sort of a gap. That's what we fulfilled, that you don't have to have remote history. Even if you're coming in with acute MI, it is safe and you reduce the risk of heart failure hospitalizations.
Great. So what are the implications for clinical practice here? You actually recently published, just simultaneously actually, right, some data about ejection fraction and congestion that may be relevant to clinicians. Do you want to just summarize those papers too?
Yeah, so so one question comes up is that, well, is there a difference between ranges of ejection fraction or congestion, or what about the combination of the two? So what we found were really things that we could have predicted anyways. That is that the lower the ejection fraction, the higher the risk, the more the congestion, and lower the ejection fraction, sort of the risk was multiplying. But the benefit was seen pretty much in all of the groups. So it wasn't like that one group was benefiting, one group was not benefiting. So I think from a clinician perspective, there may be some interest where you can say, well, the higher risk patients have a higher absolute risk, so they may have more absolute risk reduction, but the relative risk reduction for heart failure was seen pretty much in all patients.
Stefan, what's the implications on clinical practice of the Impact MI trial?
I think it's fairly straightforward. If you have a patient with an infarct, you, of course, stabilize the patient, treat the patient for the acute kind of problems. But if you then consider future care of this patient, and if amongst the worries you might have for that patient is a worry that this patient may develop heart failure, well, then use an SGLT2 inhibitor. If for some reason you're not worried about heart failure development in this particular case, then maybe you don't want to use this. But whenever that isn't, I think that's the vast majority of patients post-MI, you should consider this.
Great. And Mervat, I want your perspective as an interventional cardiologist as well.
I think all these trials teach us as interventional cardiologists that our work doesn't stop when the patient leaves the cath lab, once the stent is placed. Actually, the work starts after. And I think what it tells us is that we have a cushion, the trials, some 7 days, some up to 14 days to initiate, the guideline-directed medical therapy. And so we can tailor it individually to the patients. But what I learned from Impact MI is that actually the work also continues once the patient is discharged home. So we need to continue to optimize, because what we see from what Professor Butler just told us is that when they did the exploratory analysis, they saw that the outpatient heart failures were actually significantly reduced with the empagliflozin. So in my perspective, patients who are significantly hypotensive, or there's concern about blood pressure and kidneys and so on, I think EMPA is probably the safest to start with, and then gradually build up with some of the other agents. And I think that's what a tailored approach, in my opinion, is going to be.
Wonderful. So can I ask everyone for their key takeaways? Stefan, I'm going to start with you.
Use SGLT2 inhibitors in your cardiovascular patients that are vulnerable to deterioration, regardless of whether it's diabetic patients, heart failure patients, CKD patients, post-MI patients, SGLT2 inhibition is easy to do. And with empagliflozin and also dapagliflozin, we have drugs that in several areas have proven efficacious kind of results. It's straightforward. Just don't forget to do it.
Wonderful. Mervat, your key takeaways?
Well, I'm just learning to work with my heart failure experts a lot closer, and it's really a teamwork. I start in the cath lab, and they take over from then onwards. So I think that's my takeaway, is really focus on guideline-directed medical therapy. I think SGLT2 inhibitors, we have a lot of cushion in the room to use them.
Yeah, so I've been sort of thinking about this a little bit. So now I'm taking away off my trialist hat and putting on my clinical hat. So this is not about alpha protection and hierarchy. I'm just giving you my sort of clinical interpretation, the way I'm sort of seeing these data. So if somebody comes in with myocardial infarction and they already have an indication for SGLT2 inhibitors, now what we have found is that they are very safe to start in the setting of myocardial infarction. So if you have diabetes, if you have chronic kidney disease, if you already have a history of heart failure, go ahead and start that therapy. Now, if you get a patient with acute myocardial infarction who does not have any other indication, they don't have heart failure, they don't have CKD, they don't have a diabetes. So what do you do in that class? My opinion is, based on looking at the totality of evidence, if they meet the criteria, i.e. drop in EF or congestion, if they have non-STEMI, not only did those patients not have a higher risk, annualized event rate in the placebo arm for STEMI was about 8, for non-STEMI was about 12, so about a 30% high risk. In those patients, and those patients are obviously already sort of cardiometabolically enriched with morbidities, the non-STEMIs, even the point estimate of benefit was significantly more than STEMI. So non-STEMI patient, I would start an SGLT2 inhibitor in those patients. If you have a STEMI patient, comes in on time, gets an angioplasty, 2 days home, going better and is doing better, that's the patient you might want to follow. Although if you do an angioplasty and the EF doesn't recover, or they have persistent need for diuretics or something like that, then I will start an SGLT2 inhibitor first. So already have an indication, start. Non-STEMI, start. Is STEMI with no recovery of EF, consider. But STEMI, EF got all the way back to normal and the person is feeling great, you might want to watch that person.
Wow, okay, that's a great summary. I think all the clinicians should listen to that. I think that's great advice, particularly from the PI of the IMPACT-MI trial. So thank you for joining us today. And really, we've examined the role of SGLT2 inhibitors in terms of disease-modifying therapy across patient phenotypes in different clinical scenarios. And certainly the totality of evidence for SGLT2 inhibitors does show strong signal for reduction in heart failure hospitalization. So thank you for joining us today, Javed, Stefan, Mervat, for joining us from afar. And I hope you enjoyed this presentation.